But the trouble is that your assessment of this also is determined by the bone loss assessment and how you're going to recreate the stability for your tibial platform, for instance. And then also stability also comes in. So you have to have a circular process of dealing with bone loss, stability, and joint line restoration all the way through your revision. We've heard about the Aubrey Classification, which is probably the best classification for bone loss. Obviously 1, 2A, 2B. 2B is bicondylar, 2A is unicondylar. And then the 3 is where you're down to the diathesis. The bone loss is very extensive. And these are really the lesions that we're trying to deal with the use of cones. And it's all balanced up to getting your tibial platform in the right situation to actually allow you to get your patella to track properly, not have a bar heart and get impingement on the polyethylene where you put those in to get your joint line restoration. So I'm going to sort of advocate the use of cones. And I suppose in the scheme of things, it's a bit like India playing Pakistan at cricket. This is quite a contentious issue. And we're going to hear from Phil from Manchester talking about his use of sleeves. There's no doubt about it. Revision knee surgeons are polarised on the advantages and disadvantages of sleeves as they are of cones. And I suspect they're useful in different situations. I'm going to sort of put the advantage of cones. And this is a reason why I use cones. This is cancellous bone, and this is porous tantalum, which you can see matches cancellous bone. So what we're doing by bringing trabecular metal into the reconstruction, as Zaki said in his talk, we are augmenting that corticated bone and trying to give it this cancellous structure that we have lost by being a revision. And then he's got these struts of tantalum. And these are struts which give it that high coefficient of friction. The fact that you can actually wedge into the bone with great initial stability. So stable that bone will then easily grow through this porous structure to get, hopefully, long-term durable fixation. Now, we've been using this structure, as you heard yesterday, in the acetabulum for nearly 15 years now. And actually, it was I used this system in my first knee. And this was a case about 10 years ago that I was asked to go and give a hand in my adjacent theatre. A complex revision that was being undertaken by one of my colleagues. Once they took all the metalwork out, they had a big defect in the tibia. And rather than just put cement there with the poor fixation of cement, he asked me to put some hip augments in. So we came in and we put these acetabular augments in the tibia. And you can see how we're recreating the plateau on which we could then cement into. And we ended up sort of doing this type of reconstruction, a distal femur, augments in the tibia, but you'll hear from the zonal fixation later, we're getting good cemented fixation into those augments in zone 1, probably getting some metaphyseal fixation as well, and then we did a cemented stem for diaphyseal fixation. But then, luckily, trabecular metal got made into cones. It was initially called shapes, but I think cones are a much better name for it. And they've got both femoral cones and tibial cones. And I think that this has made a big improvement in the sort of the type 3 defects that you're getting. Just have a look at this picture. This was the corticated bone that you had before you started, and you put this in, and you've got good fixation, uncemented fixation on the outside of the cone, but inside there's a porous structure that will accept cement to give you much better cemented fixation internally. And this is a case again, sort of recreating the plateau with a cone. This is the primary situation. Look at all that medullary bone that will take cement. But here we're making an attempt at getting that medullary bone by putting that cone. In this case, you can see we're getting probably both type 1 and type 2 fixation. And then here we're supporting the fixation as well with an uncemented stem with a press fit in the diaphysis. So it's augmenting the fixation in where you would normally have pretty poor corticated bone, very similar to the acetabulum we deal with, where we think that this really does make a big difference. And you can also stack your cones. So if you feel you've got a big defect like here, you can make these very adaptable. So here we're getting zone 1 and 2 support, metaphyseal and epiphyseal support, putting these cones in, and you can see how there's going to be cement going onto the top, also inside, but actually outside there's no cement at all. That's where you're going to get bone incorporation into the augments. Now, we've also been able to use these implants with the development into segmental technology as well. And I think the segments have come on a long way since the 20th century use of endoprosthesis. And now we're trying with collars here to try and get biological incorporation of the skeleton into the implant. If you can get a collar in fixation and you can get this type of pattern, you're sealing off that bone cement interface. And you're loading the bone here, so you're not going to get any retraction. Potentially, you're not going to get any aseptic loosening occurring around the stem. And so this is the pattern that you get with the trabecular collar as well. So I think it's now, if you can, to try and get some form of collared implant, it really will help with durability of your construct. Because we know that trabecular metal accepts bone into the pore structure in about 4 weeks, very nicely mature at 6 to 8 weeks. And that's what we're trying to do with our reconstructions. And we can also see soft tissue go into this porous structure as well. This was a block of trabecular put into a spinal model, and you can see how fibrous tissue, and it's vascularized fibrous tissue, is going throughout this porous structure. And so we've been able to sort of develop the segmental now to the proximal tibia, where you have these attachment points on the proximal tibia, or porous metal, to try and aid the reconstruction of your extensor mechanism. And the tumour surgeons will know a lot about this. When they are reconstructing the proximal tibia, they need to attach the extensor mechanism back on. And by having this porous material, you can get much better and earlier incorporation of the extensor mechanism. You do have to always augment it with a gastroc flap, so we do keep it still for about 6 weeks. And what you're trying to do is then get a knee bending, which has got no extensor lag, like this lady who's had a proximal tibial reconstruction. But that reconstruction is complicated with the gastroc flap, so if you still have the typical tubercle, I try and reconstruct with the cones rather than go to a tumor prosthesis. Whereas in the femur, I've got a lower threshold for doing a distal femur and not using cones. But the tibia, I think, try and use cones in almost all cases. So much so, this case was referred to me. It was a young lady after a road traffic accident, a Schatzker 6 fracture that had been treated conservatively for 4 months. This was referred for a typical proximal tibia. But if you look at the CT scan, albeit it's smashed, there's still a typical tubercle there. So in this case, we were able to reconstruct by just trying to fling a wire around the proximal tibia to bring together the bone fragments. And then inside the tibia, we were able to get some endosteal fixation with double stacking of the cones and getting a really big press fit into the tibia. And then that's giving a good base on which we put an RHK. And you can see that's the wire around to sort of bring the bones together. But this was giving good fixation in zone 1, 2, and was supported by the diaphyseal uncemented stem. So these cones come in numerous sizes, tibia and femoral. These are more epiphyseal, these are more for the metaphysis. You can sort of mix and match. There's no real sort of order to it. You just basically put in the augment that you think is best. There's a number of different instrument trays with brooches. The normal sort of way you do it is in the tibia. You would tend to sort of work out where your tibial tray needs to sit. You would align it with a rod, and then you ream and you broach to sort of make some space. But on the whole, this takes some time, and I would tend to just get the burr out and just make a space in the tibia and just sort of use the trials to assess which is the best size tibia to give yourself support and reconstruct the plateau. So I think using a burr, it doesn't need to be a high speed, just be a routine burr, can gently help you before you implant the real implant. And the same thing for the femur. You can sort of approach over alignment rod, trial, but yeah, so sometimes a burr just to sort of fashion the space to fit the trial is just as good as the use of little brooches. And then you implant. This is a gentleman who's had a bad time with revision knees. He's already on his second revision knee, which unfortunately has now got infected. This is his first revision, which didn't do well as well. So he's only 46, and he's on his third revision. So with an infected, we did a 2-stage. This is his spacer. And the sad thing about it was, with that spacer, and that's his knee post-operatively, he said that's the best knee he's ever had. But we do really need to put a second stage in. So we came to sort of re-expose the knee, so good extensive synovectomy to allow yourself to avert the patella to get access. Then you've got to look at what existing landmarks you've got. You haven't really got much here apart from maybe a little bit of the medial epicondyle. The first thing is to reconstruct the tibial platform. Here I did feel I wanted to support the tibia, so we had a cone on the tibia to reconstruct the platform, trying to assess what height of the tibia, knowing that all we've got really to assess the height of the tibia is going to be where our patella is. And then we stabilise the knee inflection. We're just trekking early just to make sure that when we're going to get an extension, that we're going to have our patella sitting in the trochlear groove as it goes through flexion, to make sure we're not going to be too low with our patella. And we've got to then assess whether we need augmentation and extension. And here we felt we needed to get some more support in the femur, so we've gone and put a femoral cone in, more in the metaphysis. I couldn't really fit an epiphyseal sort of augment in here. So this is just going to give some zone 2 fixation. And we also wanted to augment the femur as well, to distalize, to make sure we had the patella sitting in the trochlear groove in extension. This is actually a 50mm augment. You can't put the unitized 50mm augment because I've got a posterior augment as well. So you sometimes have to cement augments together to get the appropriate level of augmentation distally. And we cemented it in. And this is just to sort of show that we got the joint line right, because the patella sits over the trochlear groove in extension, and we get the tracking right when it comes to flexion, and also there's no impingement, so hopefully we get a reasonable rate of flexion in it. And this is what we're left with, really. We've got we're getting sort of fixation, good uncemented stem in the diaphysis, so I think we're getting good fixation there. I think we're getting good fixation in the metaphysis with that cone. With cement inside. I would accept there's probably questionable fixation on those deficient epicondyles. And then in the tibia, I think we're getting good fixation down at the zone 1-2, where the cone is in the tibia. And we're getting, again, as a 46-year-old gentleman, I went for an uncemented stem in the tibia. So 2 out of 3 in both the femur and tibia is giving us, I think, sort of satisfactory fixation for this implant. I think there are some more extreme situations which maybe is where sleeves do have a limit, but I think that cones can deal with a lot of big defects. This was a 21-year-old who had a giant cell tumour that kept recurring. So we actually had to sort of reconstruct by actually resecting all of the giant cell tumour, but we kept the lateral cortex and the tibia. And this was really what we were left with, the defect underneath the tibial component that we were left with, which can be relatively easily dealt with a cone. Impacted that down, very good fixation, a press fit fixation with the high coefficient of friction. You can't remove that unless you get an osteotome to it. And on top of that, we augmented, and we were able to end up with a CR knee. I didn't really want to do an RHK in a 21-year-old. And we were able to balance with we kept the collaterals, and we were able to keep a CR knee for this lady, and she's got reasonable function, but we've been able to deal with that bone defect with that cone. Severe osteolytic case, 56-year-old, had this about 10 years. She's got lots of lysis, you can see around the femur, significant amount of lysis around the tibia, but the typical tubercle's okay. The patella component was also loose. In this case, we were just going to do a double stacked cone system in the tibia, getting zone 1 and 2 fixation with these cones. There was going to be we didn't really want to take all the cement from in the rest of the tibia, so we used this short, stubby stem component for an RHK knee. And we actually also had to revise the patella. And this is a patellar augmentation system made out of trabecular metal that you can just suture into the shell of patella. And into that you can then cement a patellar button. Because there is some evidence that this will improve her extensor function with the lever arm of the patellar button. And that was the X-ray of the trabecular button here with the cemented patellar arm inside it. And so this is what we started with. You can see significant bone loss. This is what we ended up with. Cone, and a small cemented stem, but very good zone 1, 2 fixation with the cone, supporting the RHK, and then we actually did do a segmental distal femur as well. Then we got reasonable function with this lady. I kept her sort of get touch weight bearing just for a few weeks to let bone incorporate into those cones, and this is her sort of function that she gets. Good flexion to past 90 degrees and comfortable weight bearing. So the literature is showing some good early to mid-term results with the use of cones in complex revisions, 26 Aubrey 2s and 3s, no failures of 3 years in this short-term paper. Smith's only 2 out of 44 failures, again in complex cases. The Mayo is now reporting mid-term results of over 95% survival in 2A defects, in work greater than 2A defects, and in this small series as well. Good success rate, so it certainly does seem to be augmenting the fixation. So I think these cones are being increasingly used in both hip and knee revision arthroplasty. I think we're building on our experience of the biological fixation we're getting in the acetabulum. We're now getting into the femur and tibia, and we're getting some very promising short to mid-term results. And if we can, it's avoiding us using distal femurs or proximal tibias, which again would have a cost benefit as well. Thank you very much.